Good afternoon, and welcome to the Gaines Center's webinar, Drug Treatment Court Opioid Overdose Prevention Framework. I am Melissa Neal Stein, and I'm a Senior Research Associate at Policy Research Associates and the lead for communications out of SAMHSA's Gaines Center. And I have just a few housekeeping remarks. First, the views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services or the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Throughout the presentations, we welcome you to submit questions, and you will see on the right side of your screen there is a Q&A portal. You can click that to expand it, and you're welcome to enter questions throughout the presentations, and we will be answering questions at the conclusion of the presentation. You also should have just seen a poll pop up, and we really welcome your participation in this poll. We like to know who is joining us from, what type of area and from what type of organization you may be joining us from. This webinar is being recorded, and we will disseminate slides via the Gaines listserv in the upcoming days, and we will disseminate a link to the recording once it is approved to be posted on SAMHSA's YouTube channel. And many of you asked for a certificate of attendance, so we will make one available for download at the end of the webinar. We do not provide, or we are not affiliated with any organization to provide CEU credits. However, you can use this for your personal portfolio and any crediting agency that accepts this type of certificate. Just a brief overlook of our agenda. We have John Berg here from SAMHSA, who will be providing some opening remarks. And then Jack Charrier and Michelle Warwick will be presenting an opioid overdose prevention framework for drug and treatment court settings. And we'll end, as I said before, with some time to answer questions. For now, I'm going to turn it over to John Berg, Senior Public Health Advisor for the Center for Substance Abuse Treatment at SAMHSA, for some opening remarks.
Great. Thank you, Dr. Stein. And welcome to today's webinar, Drug Treatment Court Opioid Overdose Prevention Framework. We appreciate you taking the time today to participate in today's informative webinar. Opioid overdose continues to be a major public health problem in the United States. It has contributed significantly to overdose deaths among those who use or misuse illicit and prescription opioids. Drug overdose is a leading cause of death among formerly incarcerated individuals. Prisoners and jail inmates released to the community are between 10 and 40 times more likely to die of an opioid overdose than the general population, especially within the first few weeks after reentering society. Our nation faces a crisis of overdose deaths from opioids, including heroin, illicit fentanyl, and prescription opioids. Drug courts are well positioned to help address this crisis and prevent overdose deaths among those being released from the criminal justice system. An important area of concern for SAMHSA is promoting policies and practices to lower the risk of overdose, specifically for persons with opioid use disorder who are or have been in contact with the criminal justice systems. This webinar will introduce a framework of critical activities targeting those involved in drug treatment courts who are at highest risk of opioid overdose to reduce the number of overdose deaths among court participants and graduates. SAMHSA recently released an evidence-based resource guide titled Use of Medication-Assisted Treatment for Opioid Use Disorder in Criminal Justice Settings. This guide focuses on using medication-assisted treatment for opioid use disorder in jails and prisons and during the reentry process when justice-involved persons return to the community. It provides an overview of policies and evidence-based practices that reduce the risk of overdose and relapse. Another resource is SAMHSA's Opioid Overdose Prevention Toolkit. This toolkit offers strategies to health care providers, communities, and local governments for developing practices and policies to help prevent opioid-related overdoses and deaths. Both documents will be provided for download at the end of the webinar as a resource and also can be found on the SAMHSA website at samhsa.gov. We are pleased to have Jack Charrier and Michelle Warbeck present on this very important topic and want to thank them for sharing their expertise today. I would also like to thank the Gain Center and their staff for their work in developing and facilitating today's webinar. And at this time, I will turn it back to Dr. Stein.
Thank you, John. And now I'd like to present our presenters for today. Jack Charrier leads the Treatment Alternatives for Safe Communities Center for Health and Justice, and he's the Executive Director. And he's also the co-founder of the Police Treatment and Community Collaborative and is a national leader in growing efforts to increase deflection and pre-arrest diversion. He led the development of a framework for preventing and reducing opioid overdose and death among justice populations, and he is a member of the National Opioid Library Advisory Board. And Michelle Warbeck is Vice President and Chief Counsel for Treatment Alternatives for Safe Communities, and she previously served on the bench in Ohio for 7 years, presiding over both criminal and civil cases, as well as drug, mental health, and veteran courts. And she was also previously policy counsel for the Supreme Court of Ohio. She's led a number of leadership positions. She's held a number of leadership positions, including serving as a board member of the National Alliance for Model State Drug Laws. And so you know your presenters now, and I'd like to just check and see who all is joining us from across the country. We're seeing about a third of you all are calling in from urban settings, with a little bit, with fewer calling in from rural settings, and then our smallest group there calling in from suburban settings. And I would say from looking at the organizations, we're seeing a good proportion of people joining from government, probation and parole, and the judiciary. We're also seeing folks calling in from policy type positions, corrections, academia, crisis services providers, and as well as community-based providers. So thank you all so much for joining us this afternoon, and I'm now going to turn it over to Jack to begin our presentations.
Good afternoon, everybody, and thank you, Dr. Stein. It's a pleasure to be with everybody today. We're going to run through first just a little bit of opening and introduction and then get right into the heart of the presentation. You should see on the screen right now for you the agenda for today. I don't read slides, so I won't do it for this one. I will point out, however, that the 5 critical activities framework that we're going to present was designed for a reentry population, and so I see folks on there from corrections and from probation and parole, and so some of this might sound familiar. From the court side, a little bit less familiar because it picks up elements of activities that occur really in the community and in an environment that is more where folks who are out on the streets are dealing with people that we find are in drug courts, drug treatment courts. So just want to lay that out. If you've not seen this framework, it's probably just because in your background you've not had opportunity to encounter it. That is our agenda for today, and as you heard Dr. Stein state, we will have time for Q&A at the end, and we're very much looking forward to that, as well as your comments and thoughts about the application of this reentry from jail and prison framework to drug treatment courts. You see on the screen now the purpose of the training, and of course what's highlighted in bold is the most important element. I already went over the framework. Notice the focus here is on those who are at highest risk of opiate overdose. So like so many things that we do in the criminal justice arena, we want to make sure that we are bringing in the element of risk, and in this case we're talking about risk of overdose, so not criminogenic risk. I want to separate those two out. This is a clinical risk, and that is our target population. In other words, this framework is a heavy build framework, and if you had folks for whom they are not at high risk of opiate overdose, this is too much work, if you will, too much build for that population. So just keep that in mind, and we're going to hit on that again in 1 second. Here's the objectives for today, and as you read those, I want you to focus in especially on number 3, the idea of anything that we learn kind of in our sphere of professional development, hopefully, is that we can go back and doing something meaningful with it with the folks that we work with and in the communities that we serve. And so we really do want to make sure that when you leave today, and this can be a good topic for Q&A, that you have the ability to begin some basic planning around these 5 critical activities. We're not just giving you information to kind of ponder, but to ponder and go do something with. So whether as a result of Q&A following the webinar and or for follow-up, we really want to make that the takeaway that you go and do something with it that's useful and practical and saves lives in your community. All right, so let's get to the 5 critical activities. Michelle will be going into these in depth, but here they are on the screen right now. And again, you'll get a little bit more detail on what these all mean. When you think about these put together, what you're seeing then is a package that really wraps around the person, their home, where they go to and from, not only the court, but the home and work, and does everything possible to try to save their life. That's the way to really think about this, is we are trying to save lives. And for this high-risk population, these activities are the ones that relate to doing just that. Now, they do other things too, which we'll see in a second, but again, it's really about, can we reduce the number of overdoses in the first place, and secondly, can we reduce overdose death? Other elements go with it to be sure, but for the high risk that this population represents in that arena, we wouldn't be doing these 5 activities taking as a whole. And as I said, Michelle will get to these in a minute. When we think about putting these 5 together, as I said, and it's kind of, you see the gears and the sprockets that are on the screen right now, we really are about lives saved, so the center of the bottom right gear. There's other things also, of course, that are important, and you can read those on the screen. I do want to draw attention in the crime and drug use reduction, you know, everything ultimately, since we are players and actors in the justice system, really has to get at crime reduction, and we know that reducing drug use leads to reducing criminal activity, and so you can see that that's tied into this too. So while I open up by saying this is about lives saved, of course it is. That is that is an ultimate goal. We have the other elements that make this up too. So they're not detached from that, even though we're talking about a clinical space of high risk of overdose and overdose death is the population we're targeting. The activities, the drug-seeking behaviors that some of these folks might engage in also lead to things that we want to avoid happening also. Again, getting back to the target population before we get into the 5 critical activities, you can see that on here. What we also provide you on this slide is some of the ways in which you could identify who these folks are that are best suited in your courts for these type of activities. I'll say this again, not for sake of repeating it, just because it needs to be said, is that the work that's needed for these 5 critical activities is pretty heavy. So you don't want to be doing this for a population that's not sitting within the target group. So just kind of keep that in mind as you look over who should we be targeting and how do we get at who they are. If you don't come up with the population that fits correctly, consider, do we even need to be doing this again, because the amount of work and energy and effort that goes into it that's commensurate with a high-risk population, whether that's clinical or criminogenic or both, and often they are related to each other. Those kind of interventions, as we know, take more time and resources and efforts and should only be applied to the right risk group. And finally, and when we originally put this framework together a couple of years ago, this was not as wide known, but one of the newer tools that's available, and it'd be a great polling question actually, is how many of you have access to the PDMP, the Prescription Drug Monitoring Program, in your state. So this is just something for you to take a look at, like the last slide, kind of how do we identify the target population. If you have access to PDMP or you're not sure if you do, take a look at that, because that can provide some really good information, not only, again, it's a target population, but also ongoing at reducing overdose and overdose death. So that's a very, very quick introduction. Obviously, I'll be around during the Q&A, and as kind of the developer of the framework, I'm very interested in what Michelle's done with this to make sure that it translates into the court setting, and very excited to be doing this presentation with her. So with that said, let me turn this over to Michelle right now.
Thank you, Jack. I appreciate that. Jack and I do a lot of these things, and I tend to be very detail-oriented. So you will see he did a great job presenting the framework and developing it. And so now we're just going to see what it looks like in a drug treatment court setting. And one thing I'll say off the bat is that some of these concepts may already be reflected in your drug treatment court. So as you approach this, I would say that it's important to ensure that this entire framework is intentionally and purposefully applied to those people that are at the highest risk for overdose. And so some of these may be a good reminder, but I think you'll probably find some ideas and a way to wrap around those at most risk a little bit more completely. So the first activity was minimizing drug-enabling housing. And here are a few reasons why we do this. When you think of your home, it's except when I'm at work, the place where I spend most of my time. And I think when you look at drug treatment court participants, it's not unusual at the beginning of their time in the program that they might not be able to hold down a job or vocational work, training, school. So they may spend even more time in their homes than you and I might be able to do. And that time can, until they start engaging in treatment and some of these other activities, be particularly unstructured. Now, why is that a concern? Well, the very first item on this list is people, places, and things. And so if you've been working in this arena for much at all, this phrase should be familiar for you. But when you think about the home setting, think about the individuals that you encounter there, the individuals that may live there with you, your family, friends that may come to visit, also neighbors or individuals that come to the house. When you look at the house itself, the places, you can be impacted by the home in general. You may be particularly impacted by parts of the home that could serve as triggers or reminders of drug activity. And really your home is not just the building that you live in, it's the entire neighborhood. And so again, when you're looking at drug-enabling housing, you want to think more broadly, really focus in on that whole neighborhood and whether or not it's supportive of, if it's drug-enabling or if it's supportive of recovery. And then finally, the things. What have you done there? What do you do there? Thinking about if someone is going to return to the same home that they were at before they entered a drug treatment court, is that going to be a place that will enable them to quit using drugs, or is it something that is more likely to have them return to the habits that placed them in court to begin with? And so people, places, and things, as we've seen, they can all be found in the home. And even if the actual drugs and paraphernalia are no longer there, as I mentioned, there can be triggers and memories of experiences there. That's particularly salient, and so it is likely to still impact the individual that you're working with. And then there are others in the home that might be in recovery or not in recovery and actively using drugs. So this is why the home is particularly important. So we think about how this applies to the drug treatment court. And what I'll do, if there are some adult drug court best practice standards, I will point those to you so that after the webinar, if you want to go there for a little bit more information, you can. And this one is grounded particularly in Standard 6. And there it talks about how drug treatment courts connect participants with complementary treatment and social services for conditions that co-occur with substance abuse and are likely to interfere with their compliance in drug treatment court, reduce recidivism, or diminish treatment gains. Specifically, they talk about housing in that section and indicate that safe, stable, and drug-free housing are needed at the beginning of Phase 1 as well as continued throughout the program. Another caution, so you may be thinking, well, what if there isn't drug-free housing or stable housing for the individual? And the standards specifically talk about how this should not be used as an exclusion for someone from a drug treatment court. So not only do we see how housing impacts individuals, but the standards would indicate that you need to include individuals even when they may only have available right now drug-enabling housing, and that means that you must address that through your program. So lots of whys as well as how it relates to drug treatment courts. So what do you do? You're probably already doing some activities with housing. This tends to be a subject of a high priority with drug treatment court treatment teams throughout the whole process. But here are some specific things according to this activity in the model. You want to make sure that you begin gathering information about housing. You start off with referral sources, and so this would include police. They may have indicated that this individual would benefit from drug treatment court, counsel, defense counsel, or even the prosecutor and what they know about the housing situation and any concerns they have about it. There may be things from court records that would give you concern about housing, especially if someone is going to return to their present housing, and even family members that have referred someone to drug treatment court, again, would be good outside information about housing. Then as the individual enters into drug treatment court and you engage them in skilled interviews during the initial intake and assessment, that's an opportunity for them to share with you any concerns they have about housing. Now, of course, that's self-report, and so that may or may not paint a complete picture of everything you need to know. But again, it's important to understand from their perspective if they have any concerns about housing. In person is something that I definitely want to draw your attention to. And Jack mentioned that the framework here is important for those that are most at risk of overdose. And so many drug treatment courts will take information, self-report from individuals and maybe from referral sources and rest upon that for housing. But in these cases, it's particularly important when all possible to make an on-site visit and look in the house, look outside the house, look around the neighborhood, speak with neighbors, seek out other individuals that are interacting with that person in the home to gain a more complete, thorough picture of what this housing situation looks like. Of course, we know that that is not, intake is not the only time that we need to be concerned about housing, and if someone anticipates a visit, they may prepare for it so that you don't find anything that may be of concern. So making sure that you allocate resources to periodically revisit the home unannounced so that you see what the true ongoing conditions look like. And then finally, the last item really talks about some of the leadership of the court to help enlist housing resources that are appropriate. And that may involve talking to housing agencies, reaching out to potential landlords through Rotary or other community-based meetings. And I think judges and other individuals associated with drug treatment courts can really be articulate about the need for housing as well as advocate for placement. And oftentimes, individuals in the community, when they hear how well drug treatment court teams wrap around the participants and how much support they're able to have, they may be more willing to make housing available when otherwise that might not be something they would be interested in doing. And you will hear throughout this presentation lots of opportunities for courts to be advocates in the community. Just as important as it is to figure out what you need to know about housing, you need to decide who is going to perform that role, and oftentimes it's a cluster of individuals. I mentioned case manager. There is actually in the best practice standards, standard 6, talks specifically about clinical case management services, and they cite our task model, which is a specialized case management. Oftentimes treatment providers do case management, and it's primarily focused on making sure someone is in the appropriate level of treatment and transitioning to lower levels of care. We also have court supervision, which is primarily focused on the court expectations. So you want to make sure that if you don't have a separate specialized case manager to look at the relationships between systems, so what is falling through the cracks? What is preventing someone from accessing services? What are the other needs and strengths that the individual have? You would want to ensure that members of your treatment team are ready to pick up that role. And so here specifically with housing, you would want an individual to assess the housing situation, to make linkages to appropriate housing, and to continue monitoring through the individual participant what their housing situation looks like. Probation may, if you don't have case managers, do some of this role. They also tend to be more trained in doing home visits, or may accompany a case manager to a home visit, and so that's an important role that they can play as well. Treatment may find out through treatment settings that there are housing needs or housing concerns that they can voice to the treatment team. And sometimes if you have law enforcement and if you're a smaller community, what I found is that if law enforcement knows that someone is a participant in a drug treatment court and they're finding them in parts of the community or engaging in housing resources that the court didn't know about, they are able to bring that to the attention of the team so it can be addressed. You want to continue to monitor housing throughout the phase progression. And it's not just housing, though, that is one of the social determinants of health. And so you can see the last item on this list, if you're really looking for other needs for initial and long-term stability, a number of things there. The basics, food, clothing, medication, transportation, ability to be reached, and then also for the long-term employment and income support. And those are all things that your specialized case management, either a case manager or others performing that role, can help with. So moving along to the second activity that Jack mentioned, minimizing overdose death within 2 weeks of release. There's a good bit of research that's been around for well over a decade and has been confirmed more recently that 2 weeks of release is particularly an area of concern, but it can extend for even 6 to 8 weeks. So why this 2-week increment and even the 6 or 8 week? What we see is, you know, from the slide, there's a 12% increase in overdose deaths upon release from any residential setting where substance use has not been possible. And by any setting, that means jail, it could be residential treatment, or settings where the substances simply are not made available or permitted to have access. So this is higher than all heightened risks at reentry. It's a particular concern. When you look at tolerance and the comment about tolerance, when there has been a period of time where drug use has not taken place, then the tolerance for the higher dosages is no longer there. And so with opioids, we see that there is a higher risk for respiratory suppression. And as well, when you look at the impact of fentanyl being mixed into opioids, either suspecting or unsuspecting, that greatly increases the risk of respiratory suppression. Fentanyl is not only being mixed with opioids, but it's also being mixed with other substances. And so here at TASC, we are looking at, even if someone hasn't used prescription opioids or heroin or seeking out fentanyl, it could be mixed in with marijuana and other substances. And so we try to be on the alert of individuals who are at risk that don't initially present with an opioid use disorder. Again, looking at how does this specifically apply to a drug treatment court setting. Clients are often released from jail to a drug treatment court, sometimes at initial appearance, and even some of the assessments and decisions about whether or not someone qualifies for drug court would take place when someone is in a jail setting. And that can be for a fairly extended period of time, enough that the tolerance for the higher dosages used prior to incarceration would be of concern. It's also a concern, as I mentioned before, if someone's in residential treatment. So release from residential treatment is another one of those times where you want to be particularly concerned about access to substances. And when you look at the best practice standards, Standard 5 talks quite a bit about treatment. It does indicate that you would want to look at the ACM level of care for determining treatment. We don't assume that someone needs residential treatment, and if they don't need residential treatment, this is one of the reasons why you would not want to default to that. Also, gradual step down. The Best Practice Standard 5 talks about how studies that are well over a decade old that had already identified that when you move someone directly from residential to a lower frequency of standard outpatient treatment, that can be associated with poor outcomes unless you have a very tight wrapping around them and also a transition. And we see that this is now even more critical when we consider the increased potential for overdose death in light of the opioid, heroin, and fentanyl crisis. So what can drug courts do? As Jack mentioned, when you're doing this type of wraparound, you're not going to do this for all of your participants. So you want to make sure that you identify the highest risk individuals, looking at things like, have they had prior overdoses? Have they ever had naloxone administered? Checking into the PDMP records. All of this can be built into a screening tool to give you a quick assessment of who may need to be in this more intensive program. You also then want to obtain a full clinical assessment, and that would yield your diagnosis as well as the ASAM level of care, so you can be clear of the individuals that are at that heightened risk, and then provide quick access to the appropriate level of treatment. In this case, when you look at the risk of overdose and the potential for respiratory suppression, even a few days on a wait list can make quite a difference. And so you need to think through what support can you provide someone while they're on a wait list if that's necessary, or are there other alternatives? And again, part of this can involve reaching out into the community to make sure that you have the treatment resources necessary with the priority that needs to be placed on this. The next item you'll see is implementing policies and expectations, including information sharing. It's really important to institutionalize what you're doing here. And sometimes we see individuals will become very well educated, so they will develop ways of doing business in their drug treatment court. But if it's not institutionalized into policies, if that person leaves, others may not realize that this specific framework was being implemented and leave out key parts of wrapping around your participants. You want to make sure that you train your whole team and your stakeholders. And here at this slide, it even talks about thinking about minutes and hours, not even days, to make sure that you have those tight handoffs. The next slide talks about treatment modalities. So medication-assisted treatment for opioids would be highly recommended as medically and clinically indicated. So the role of a drug treatment court would be to identify those that may benefit from MAT and make a quick referral to a clinician who can do the full assessment to not only determine whether or not MAT is appropriate, but the appropriate form of medication that should be used. Sometimes courts hear feedback from the community or pushback that medication would replace one drug for another, and the research has certainly shown that that is not the case. And when you seek out highly qualified addiction specialists, they will be able to give your participants sound clinical advice on which modalities would be most appropriate for them. When you're looking at individuals being released from jail, and again, this is the what do you do during the first 2 weeks to make sure that you can minimize overdose death. You want to consider whether they can do some pre-release induction. And a number of jails and communities have some funding. I think Vivitrol tends to be one of the medications that you see in place here. If you do that, you also want to make sure that you have quick wraparound so that within that 28-day period, the next injection can be lined up and accessed by your participant. You want continuity of care. It's not just medication, but you do need behavioral health treatment. And you want to be careful to avoid abstinence-only treatment providers that may discourage the medication-assisted treatment. I also would say, and several years ago, we started hearing a little bit more about the Americans with Disabilities Act and the Eighth Amendment, cruel and unusual punishment, and how that may impact MAT. There are cases and court decisions now coming out indicating that treatment cannot be disrupted if someone enters into a jail or a prison and they have an opioid use disorder, whether that is MAT or other treatment, and that it should be provided. Jails do vary widely in how they handle opioid use disorder. Some of them may require withdrawal upon admission to jail. Others are going to be offering medically managed and monitored withdrawal. Some may enable treatment to continue while in custody, and some may even have programs to link individuals to Medicaid and help coordinate that coverage upon release. So it's important to find out what your local community has to offer and to advocate as much as possible that MAT is available in a timely, coordinated manner. We talked about medication-assisted treatment. It's also important to consider the role of naloxone. And so naloxone is the antidote to overdose. What you want to do is make sure that you educate the participants, their hosts and their family members, ensure that they are able to access naloxone. Many of the pharmacies now have a standing order and can provide naloxone over the counter. And we want to make sure that individuals are educated about how important that is. If you can actually provide access to naloxone to cut down on some of the steps, that is another consideration that you can offer, and clearly educating to make sure that your staff and your stakeholders are not only having access to naloxone, but understand how to use it. The third critical activity is maximizing rapid access to drug treatment. And we've already talked about that a little bit. If you look at this next slide, we want to make sure that not only do you have rapid access, but it's to the appropriate level of care, which we've talked about with the ASAM levels of care. The next item is important for drug treatment courts. Early on in drug treatment courts, some of the programs looked at whether or not the individual was motivated to change and considered using that even as entry criteria for the program. Here, the literature would indicate that engagement in treatment actually shifts that motivation to participate, and so drug treatment courts are highly effective in having their participants show up to treatment and to develop that readiness for change. The treatment should also include any co-occurring diagnoses, often mental health, and if you have veterans, they may have TBI or PTSD that should also be addressed. And many individuals are going to need not only trauma-informed treatment, but specific treatment for trauma. And we do know, as Jack mentioned, that we want to see how all of this plays into crime reduction. So the reduced drug use does have a positive impact on crime and it's been proven by research to reduce crime. So how does this apply to drug treatment courts? Again, when you look at best practice standards, Standard 5 for treatment, they have a good reminder that most participants, when they first enter into a drug treatment court, they are clinically unstable. They may be in a state of crisis when they first enter the program, and it's critical that at that point they don't fall through the cracks during early stages. This is where they're most vulnerable to cravings, withdrawal symptoms, as well as relapse. So what do drug treatments do to maximize access to drug treatment? You want to educate the systems that you work with on the importance for speed. So again, using that judicial and court leadership to work with your stakeholders, not only educating them on the importance of speed, but making sure that they have beds available or slots and treatment programs available immediately for your highest need participants. You also want to understand what your community's treatment capacity is. So Jack talked about the target population for this kind of a framework being those that are most at risk for overdose death. And as you can see, there are a lot of requirements that need to wrap around these individuals. You want to make sure that when you are serving someone in your drug treatment court that you are focusing on individuals where there is treatment available in the community. As a matter of fact, the best practice standards, when you look at Standard 1 regarding the target population, would indicate that it's critical to identify groups of individuals that can be treated both safely and effectively in your community. If you do not have the treatment modalities needed to serve these high-risk individuals, then that would be another opportunity for court leadership to explain and articulate the need for treatment expansion or the availability of different levels of care and advocate that those are made available to your clients. And again, payment for treatment is critical, so you can see conducting pre-release, when possible, Medicaid enrollment or coordination of benefits would also ensure access to treatment. Other things that courts need to look at, making sure that you have a warm handoff from custody to community-based treatment. So having someone released directly into the community and hoping that they are able to make their way to treatment would not be the kind of warm handoff that is ideal. Instead, if you can have someone even pick that individual up from jail, transport them directly to treatment, or something that is that tight. Again, we talked about the minutes and hours and how those do make a difference, especially during these first 2 weeks. Providing medically monitored withdrawal management when appropriate. And again, we talked about that jails vary widely. There are also individuals that may have entered jail and they were already on medication-assisted treatment, such as methadone or buprenorphine, so that should be continued rather than forcing those individuals to withdraw. Or it may be possible that they can be induced into a form of MAT where full clearing of the system of opioids would not be required. Of course, if they are going to engage in Vivitrol, then they would not be able to have any opioids in their system, so withdrawal would be required and should be medically monitored to ensure that there is no unintended consequence from the withdrawal itself. Developing rapid notification with a diverse or with a response team. One judge that I worked with had a special cell phone that was made available to law enforcement, and in that community, law enforcement always responded to an overdose. And so they were directed to notify the judge immediately if anyone who was a part of the drug treatment court suffered an overdose. So similar things like that could be taken advantage, if not through the judge, certainly through a probation officer, case manager, or someone else who would have immediate access to that full treatment team. And using technology, texting and calling obviously are quick ways to reach individuals. You'll want to reach out to your stakeholders and make sure that if someone is missing appointments or is not engaged in services, that there's a way that you can quickly have that information for this high-risk group of individuals. Some treatment providers may have, as a matter of course, that they send a letter in the mail offering an opportunity to reschedule. Clearly for these patients and participants, that wouldn't be sufficient under these circumstances. Some additional considerations, looking at incentives, sanctions, and therapeutic adjustments. That's the best practice standard 4. And you want to make sure that when you are looking at someone who maybe treatment, they're not responding as expected to treatment, realizing that that response is a distal goal or something that is expected to occur further in the future. Proximal goals are expectations that can be, that would be appropriate for the present time. So you want to be careful that if someone is not responding to treatment, that they're not terminated or punished, but rather they receive a therapeutic adjustment, which may include a full reassessment, reevaluating the level of care, and oftentimes once someone has been engaged in treatment, other needs surface, such as mental health conditions, trauma, or even some of those social determinants that may be interfering with the effectiveness of treatment. So making sure that you really wrap around and see what is the cause of the behavior and not relying solely upon sanctions to try to motivate someone to make progress on their treatment plan. Understanding how transitions impact individuals. Oftentimes in status review hearings, a judge may learn that someone is going to be going home to a family event where some of their relatives might have used substances. There might be a death in the family. Sometimes a transition, even moving from one phase to another and having less contact with some of the support systems is enough to trigger a risk for relapse. And so taking advantage of the full team to wrap around this, to anticipate, and again, encouraging some conversations about what individuals are anticipating and how they plan to handle some of the challenges could be particularly effective, especially in that status review hearing group setting. Employing collaborative decision-making is a given in the problem-solving court or the drug treatment court model, and so the treatment teams are regularly meeting with the judge and having a variety of viewpoints, including clinical viewpoints that can indicate what other needs this individual may have. And of course, substance use testing, which is best practice standard 7, is critical to make sure that you have accurate information about use, not just what is self-reported by a participant. The next activity is minimizing the drug market. When you look here, why would you do this and how does it have relevance to a drug treatment court? You can see some things listed on the slide. You may look at these items and wonder, although they do minimize drug market, you may wonder what the court involvement would be in these kinds of activities. It does apply to the drug treatment court because it impacts the availability of the substances that would be used by the participants. And so just looking quickly at this topic, I would encourage you to look for opportunities to exert the court leadership. Again, articulating the needs of your participants, and an exceptional or a great resource for this is its National Network for Safe Communities Drug Market Intervention. Moving on to critical activity 5, minimizing the overdose deaths beyond 2 weeks. Again, we talked about 2 weeks as a critical period, even up to 4 to 6 weeks. Why do we continue to have a special emphasis for these high-risk individuals? Well, we know that risk does reduce with treatment, but it remains there during points of transitions and things that can produce triggers. Treatment, engagement, and retention are key during this period of time and throughout the whole drug court process. We know that substance use disorders are chronic. Relapse is expected, and recovery supports are needed for the durable recovery. So specifically in a drug treatment court, that program is, when you look at court-based treatment programs, relatively long-term. They last from 12 to 18 months, and they have a series of phases designed to support participant progress. So this provides an opportunity, and I would also say an obligation, to continue minimizing the overdose death risk beyond this 2-week period. So what do you do beyond those 2 initial weeks, where you have someone in housing that's going to wrap around them, you have quick engagement in treatment that's appropriate and based upon their level of care? You want to start examining your phases and make sure that they take into account the risk of overdose in the stage of recovery. And right now, the advice is that there are shorter and more frequent, or more phases rather, to allow participants to make progress. And when you have shorter and more numbers of phases, you can employ specific elements, you can make sure that they are tailored specifically, again, for the stage of recovery where that participant is likely to be at. When needed, you don't really want to push someone back to an earlier phase, so you would want to employ elements from earlier phases as needed if someone needs a boost in their recovery. You want to consider the frequency and purpose and method of contact. So just like they are at risk, your participants could be at risk if they don't have enough contact early in their drug treatment court program. If you continue to have heavy contact requirements all the way through to the end of the program, that can pose other challenges, such as limiting their ability to engage fully in employment and other activities. So you want to make sure that you're very thoughtful phase by phase as to what's needed. Addressing all the client needs, we've talked again about mental health needs, social determinants of health, even trauma support. So making sure that throughout the drug treatment court you continue to monitor that. And you don't want someone to rely solely upon your drug treatment court team and feel like once they successfully commence from drug treatment court that they are not going to have that support. So early on, you want to make sure that you engage community supports with your participants and have those community supports play a greater role toward the end of drug treatment court, so that even when individuals no longer have court involvement, they feel like they have their base of support. You do want to continue monitoring risk factors with your treatment team and realize that treatment itself can be a trigger. So as individuals start facing some of the issues that they are working through in treatment, it may produce anxiety, it may surface trauma, it may do other things that could make relapse a potential. And so being aware of that and discussing that with your full treatment team is an important thing to monitor. We've talked about some of these concepts already, that you want to make sure that rather than solely relying upon incentives and sanctions, that you make good use of therapeutic adjustment and you are willing to assess and reassess how individuals are doing. Attendance at appointments, again, I mentioned that if someone has a standard protocol of sending a letter for rescheduling, that is something that would not address the urgency of the clinical needs at hand. So you want to make sure that you have quick responses that are proactive and reach out to the individual immediately to keep them engaged in their treatment appointments and their other necessary appointments. Toxicology reports. Considering how do you treat the missed drops, dilution, substitution, and alteration. The recommendation is that all of those are treated as a positive toxicology report and are handled, again, with clinical sensitivity as to what may be happening with the individual. And then you want to make sure that you are looking at the progress of the individual, not only their treatment plans, but also their case management plans. If they are struggling in certain areas, that you're able to identify what some of the barriers are so that you can address those. And you want to make sure that with things that are attitudinal improvements, that you consider how you are going to monitor that, who is going to share the information, how it will be shared, and if you are having some challenges, how that can be addressed. Then more ongoing treatment team considerations include compliance with your curfews, medication, procurement of unauthorized substances, new arrests and offenses, as well as behaviors that may be unwelcome towards staff and participants. And these are the kinds of things that often probation would have a primary responsibility for. All right, we have gone into lots of detail about the why we have each of these activities, the particular relevance in a drug treatment court setting, as well as lots of ideas of what you can do in each of these areas. So to sum it up, looking at the critical activities, what is needed for someone that is at highest risk? They need housing that doesn't support drug use, this tight wrapping around and handoffs that start immediately from your first contact, lasting at least 2 weeks, if not through that 4 to 6 week period. Rapid access to all the needed treatment, not just for drug or substance use. Some advocacy in the community for the resources that are needed, including an opportunity to impact and minimize the drug market activity, and also the ongoing monitoring and recovery support, not only for the substance use disorder, but also social determinants of health. Great, and with that, I will turn this back over to Dr. Stein.
All right, thank you so much. Okay, so we are now in the Q&A portion of our presentation, and so we welcome you to submit your questions. As you can see again on the right side of your screen, you should see a portal that's called Q&A. If you click that, it will expand and you'll see a box where you can enter in a question. And so I just highly encourage you to submit your questions now regarding anything that you've heard about this throughout this presentation. And I think to get us kicked off, Jacques and Michelle, many of our treatment courts are not using naloxone and aren't really sure how to incorporate that into the program. Can you talk to maybe some of the fears or apprehensions around involving naloxone in the drug treatment court programming?
Sure, I can start off. I think probably one of the most common fears, and I hear this not only with drug treatment courts, but with legislators, policymakers, the advocates will talk about this as harm reduction, that it can save a life and enable someone to access treatment. On the other hand, some of the pushback may be that it may encourage people to use because they know that naloxone could be applied. That has not really been supported, but I think that is one of the common misnomers, and so any opportunity to educate that that is a misnomer would certainly be helpful to a drug treatment court. In terms of access, I can share with you in Chicagoland, we have some community agencies that are able to obtain no-cost naloxone and make that available. But the supply may not address the need. I also mentioned about pharmacies, and I think if someone has private health insurance, they have found a variety of responses. Sometimes pharmacies are not as aware. They don't have a lot of requests, and so the particular technicians on staff may not be aware about naloxone and in its distribution. There's also a variety of pricing challenges, and so if someone has private health insurance, that may or may not be covered. Without health insurance, especially Narcan, the nasal spray could be particularly expensive, and sometimes even if naloxone is available, individuals are not pushing back. They believe that it's a good idea. There could be some financial barriers.
I would add also, quite simply, that naloxone is a life-saving medication, and so its use is very simple, far and wide. And when you look at the 5 critical activities, number 2, minimize overdose deaths within 2 weeks of release, and number 5, minimize overdose deaths beyond 2 weeks, this is the medication that is used to reverse overdoses. As such, as far and wide as you can go with it, the participant, their family, their friends, and anybody else who you can give it to is absolutely fine and should be done across the board. Number one, minimize drug-enabling housing, that critical activity. If you do not have probation staff that are up to par, and I say it very bluntly that way, in terms of understanding whether or not the housing is increasing drug use or increasing the likelihood of drug use, especially for someone with opioid use disorder, then having the availability of naloxone is even doubly critical so that the family and the individual themselves have access to it. And so kind of on those three critical activities alone, it makes tons of sense to have it to save people's lives. You remember at the end of the day, of course, someone who dies does not successfully complete the court program, and I'm not being funny when I say that. That is a failure of the program when we have access to the medication and should be able to give it out as far and wide as we can.
Thank you, Jack. So we had a question come in from the chat box. Someone asked, can you give examples on how the treatment team reports, how they could report attitude issues or participation issues in treatment back to the entire team? So how do you effectively communicate those kinds of issues from the treatment side back to the entire drug treatment team? Either Jack or Michelle, would you want to answer that?
Well, I'd be glad to jump in on that one. I think some treatment teams kind of naturally are able to talk about how someone's motivation or their attitudes are changing. Others need a little bit more structure. And so some things that may help, especially with the newer treatment team or treatment providers, is to have a form or a list of questions or topics that would be addressed. Treatment providers would not be expected to give all the clinical information they learned through the relationship with the client, but it's helpful for the court to understand, of course, very basic information, like is someone attending? Are they attending all the sessions? Are they there on time? And are they staying through the whole session? At the beginning, when we talk about proximal goals, sometimes that's about all that's expected. Once the substances clear their system, individuals start shifting and they are becoming more participatory, showing that they are learning the information and applying it, and their motivation to attend may be shifting from a court compliance motivator to how they're benefiting personally. Those kinds of things, again, either because it's the nature of the conversation or through some kind of paperwork, you can have prompts to have treatment providers, even if you are having a case manager report on their behalf, just have treatment providers indicate on scales or put some comments about how the motivation and attitudes are progressing. You don't want to punish someone, again, that initially may not be showing a lot of internal motivation to engage in treatment, but it's a nice opportunity to see that shift. I think it is shows as a reinforcement that some of the things that you're doing are working. I would also share outside of the treatment team, so once the treatment team has had discussed this, it's possible for the judge to have some of those conversations in the status review hearing. And again, maybe checking in when at phase advancement, oftentimes I would see judges that would check in with the participants and ask, maybe how are you changing? What are you learning? And asking some questions that kind of get at some of their motivation. Oftentimes between phase 1 and phase 2, or certainly between phase 2 and phase 3, there's a lot of evidence of those shifts taking place. And so another way, although not specifically for the treatment team, but some courts even have an application that participants fill out for phase advancement that would allow them to comment on their motivations and how they feel the process is impacting them.
Great. Anything to add to that, Jack?
No.
Okay. I think along the lines of communications, we had another question come in about use of technology and smartphones. Someone asked, do you know of any courts that are using a smartphone solution to help clients access educational content and social determinants of health as well as communicate with the agency and behavioral health team?
I don't have any specific court examples. I know there are more and more apps available, and so that might be something more through a treatment provider than the court itself. I do know in our case management model, we don't have a lot of communication via smartphone, but we're definitely doing things like texting, not texting protected health information, but making sure that there are reminders that can go out to our clients so that they attend appointments, especially individuals that are not as good at managing their own schedule. I don't know, Jack, you may in your travels have encountered groups that use a more technology app-based program.
Yeah, I'll see if I can find one of them before we finish up today's webinar. I'm actually looking for one that I was looking at a couple weeks ago, so let me see if I can find it. It is a platform that works with criminal justice and people who have substance use disorders that are criminal justice involved, and I believe is being used right now with Massachusetts parole and probation on the reentry side as well as in New Jersey. So let me just see if I can find that before the webinar is over. So ask a few more questions, buy me a little bit more time, and I should be able to find this. If not, I'll send it as a follow-up email.
Okay, thank you. So someone asked about courts overall, and kind of getting back to one of our previous questions about naloxone, this takes it a step further. This person asked, how do you address a court that only supports the use of naltrexone and not buprenorphine or methadone?
You know, I engaged in a project with that for the state of Ohio when I was there, and we were able to develop principles for the use of medication-assisted treatment in drug treatment courts. And so one of the first things we convened leaders, national, state, and local leaders that all would have a say in that subject matter. We spent 2 days sharing information, getting education, and then reaching consensus. So we wanted to make sure that the court approach was also going to be appropriate with case management and treatment and others. And the principles, and I'm not going to be able to quote them exactly anymore, but it generally indicated that it is important for the courts to identify if someone has an opioid use disorder. Once you make that identification, you need to make a referral to a trusted treatment provider that has expertise in this area. Then the individual will meet with that treatment provider, and there's a patient-physician or patient-medical provider relationship, and it's up to that team to do the full diagnostic conversation and conversation as well about medication, including which treatment is most appropriate. They've all been shown by research to be effective. So at that point, the court should not play a role on which particular method is being used or if MAT is being used at all. That the individual needs to have a right to informed consent once they have information from the treatment provider, and that's brought back to the court. So if the individual then engages in MAT and that becomes part of their treatment plan, then the court can monitor to make sure that the individual is compliant, but the court should not be dictating whether or not MAT is used, whether or not it is continued in use after successful completion of drug treatment court. That's another issue that sometimes arises. Sometimes courts were wanting individuals to cease using MAT before they graduate from drug court. And again, that's a medical decision that needs to be made by medical providers. You know, going back to the trusted provider, when you have someone that is very knowledgeable in MAT and the justice population, then courts should feel confident in what the patient and the physician are deciding together. If you have a provider that you don't have as much confidence in, there are some processes where you could bring the person to court to make sure that the decisions are in the client's best interest. But again, when you start with trusted providers that are well informed, you should avoid any, feeling that the patient or participant in the drug treatment court may not be getting the best advice. The other thing, too, is if an individual, what is appropriate for a court to monitor would be the behaviors that would indicate compliance with the program. So if someone is on a form of MAT and there are some concerns that the medication is not sufficient, just like if there are concerns that the ASM level of care for behavioral health is not sufficient, then the court can certainly give that feedback back to the treatment provider.
I would add in also when we think of these 5 critical activities, and I showed the slide that had the 3 gears and sprockets on it. I guess they're just gears actually. If you had a court that was not using all 3 medications, and with regard to what Michelle just said and what we know SAMHSA promotes, having all 3 medications available, just go back to this page that shows the gears and say, do you want to maximize your court outcomes or not? Do you want to reduce as much crime as possible or not? Do you want to reduce as much drug use or not? Do you want to save as many lives as possible or not? Do you want to have a successful court or not? I think you get the idea of what I'm trying to say here is that education matters, what Michelle said matters. At the end of the day, the outcomes should matter. And when you think about the outcomes that I just laid out that result from the 5 critical activities, why wouldn't you want to maximize those outcomes? And there's a reason of what you do with the court or a path forward in a conversation and an education with the court or group that does not have access to or does not want to use or does not use all the medications, where there are not barriers to it, or we get that there's times that there's barriers to it financially or whatever. But that's a rationale that's important to understand too that can get us beyond sometimes local arguments or philosophical arguments or point of view arguments.
Thank you for that. And someone asked, just kind of coming along the lines of thinking about treatment, she asked, would you be able to share references, especially around the framework, overdose rates after discharge from residential treatment, and across transition points?
Can you ask that question? Say that question again. I'm going to look at it on the chat box. I don't think I'm grasping it right now.
Just asking for references from your presentation, particularly around the framework, overdose rates after discharge from residential treatments, and various transition points.
Okay, I will work with, I'll follow up with John. This framework was developed as we set up front for a reentry, and SAMHSA grantees, CSAC grantees have received the framework over the last couple of years, and so I'll follow up with John on that question. Okay,
great. So we have a couple of questions coming in about the jail and that part of the process. So one person asked, please share an example of how jails can assist with warm handoffs to community-based treatment.
I have a couple examples of that, and at a very simple level, one of the things that we notice in communities is that when jails release, they may do that without any notice. So when it's your time to be released, they let you know that you can leave, and people may not even have transportation or a way of getting to where they need to go. So part of what could happen is to have a coordination so that when a jail is intending to release a drug court participant, that the drug court is notified, that they are able to, and I've seen communities have their I'm blanking on the word, their volunteers with the law enforcement. So the sheriff's auxiliary or the police auxiliary may be able to go and pick up individuals from the jail and transport them to residential treatment or other places where they need to be. Jails could certainly coordinate with the court, and if there's a residential treatment provider that's willing to pick up at the jail. Again, part of it is just having the jail being willing to indicate ahead of time when they're planning to release someone so that all of those arrangements can be made. Another example is something that TASC is involved with. It's our supportive release center. And so rather than the jail reaching out and saying ahead of time when someone is going to be released, this is something that's offered to individuals before they're released. And if they are interested, can be taken by van to a location where they can receive overnight housing, a meal, clean laundry, different things that they need. And there they actually go through an initial assessment with a nurse practitioner so that they can have access right away to any medications. They also have a chance to meet with case managers to see what initial needs can be addressed, including suitable housing. That's not part of a drug treatment court protocol, but you could certainly have something like that in an area where the jail was not willing to give specific times of release, but you would be able to, again, set up this intermediate place where straight from jail individuals could arrive, and it's an environment that is set up to meet their initial needs.
Great, thank you.
You know, let me toss one more thing in there. Another thing that can happen and for jails to do is also to coordinate distribution of naloxone upon release. So in addition to all the things we've talked about and kind of emphasizing Jack's point, and we also have a program where if people are released on their without bond, that we are there available, and we offer the training right on site for naloxone, as well as providing individuals with naloxone upon release. And then as the jail releases individuals during other points in time, again, they, at least in Cook County Jail, are offering an opportunity for those individuals to receive naloxone immediately upon release from jail.
And Dr. Stein, I do have for you, somebody asked a question earlier about an app or a smartphone app. I do have that up right now, and
okay, great.
To share it if you want to do it. Let me say up front, you know, for sake of transparency, we receive no money from this. All these apps are private sector that I've all come across. We receive no money. We're not part of this. It is the one, though, that I'm aware of is used in parts of justice system as early adoption. And it's called Dynamic Care Health, and they do have an app that relies on contingency management. And because of that, the use of that, as well as the other things that go with it, it has been recommended by the National Institutes of Health and the American Society of Addiction Medicine. So I'm not advocating for it, right? All the disclaimers that go with what I just said. But it is one that I have seen. It is used in the justice system, in probation and parole and reentry settings, and is a smartphone app, which was what the question is about. I've seen other ones, but this is one that I'm just familiar with it because I have some colleagues who work in and around this technology area in this space.
And we also had someone comment about an app. I think it's mostly about access to MAT, or medication-assisted treatment resources, but they referenced the Core 10 app and said that their MAT participants are able to use that app to access resources.
Yeah, and what we are seeing on early stage development of these apps is they really are relying on things like reminders. Some of them are about rapid access to a live treatment person, or a treatment counselor, guidance counselor, peer, 24/7. They're, again, using contingency management in there to boost the levels of participation and engagement. Some of them use GPS to keep an eye on, not from a supervision standpoint, but are people moving into areas they should not? Have they moved recently? Have they been still too long, which can indicate the possibility that someone is in overdose or is deceased. And so there's kind of a range of things going on in this application world, smartphone application world, all of which are connected in, obviously, to behavior health and entity using, not a justice entity, but a behavior health entity.
I also know of an app, although I'm sorry, I was not able to locate the name of it, but it allows individuals that have naloxone to register. And so if you are in need of naloxone, so you see someone that is overdosing, you can log in and find out the closest person to you that has naloxone. It's a little bit different purpose for the app as we're talking about technology and smartphones. That's something that's available as well.
Yep, and that one is called Naloxone Find. Naloxone Find is available on Google Play and the iTunes Store, and that is one of two apps that Michelle's referencing that allows you, she said, if you carry naloxone to register yourself as a user, and then if someone needs it, to be able to find someone nearby who has it. And of course, while not in exactly the same space, we'd be remiss if we didn't mention ODMAP, which is put out by the federal government, which is used to send responders to areas hot zones where people are saying that overdoses are occurring, and that's called OD map.
Okay, thank you. We did have one more question around about jails and their role. Someone asked if you could describe what are the barriers to getting Vivitrol injections in the jails. Would either of you feel comfortable answering that?
I think one barrier would be the cost. That is, some jails don't provide any treatment, so individuals don't tend to be in jail. They're in jail for prisons for longer periods of time. They can be in jail for a longer period of time, but sometimes it's a relatively short period of time, so it could be just providing access to medical care at all in that short of a period. For Vivitrol specifically, that is a more expensive medication, so sometimes it's a cost barrier. I've certainly seen communities coordinate so that immediately upon release, someone is literally taken to a Vivitrol provider, and they can go ahead and have that initial assessment and even receive the initial injection. Other times there, I think, have been ways to have that provided on site. It can be a payer source, so if someone is in custody, depending on what the state laws are, the state may be responsible for paying, may or may not be able to have Medicaid assist with that. So it seems to be, especially in a setting that is set up for shorter term housing, a coordination of medical resources as well as payment.
And I'll add in that one of the better resources that was just released on this topic is on the RSAT-TTA.com website. So RSAT, Residential Substance Abuse Treatment, is the Bureau of Justice Assistance funded program for jail-based and prison-based therapeutic communities. And they just released, along with the National Sheriff's Association, a guide on jail-based medication-assisted treatment. It's really, really good. It's up to date, and it covers this topic. So that's at RSAT-TTA.com. And just because I work nationally with a lot of the organizations and SAMHSA, DOJ, CSAT, all those folks, there's a lot of good resources around in this area, and I think that that's the one that I generally, in the space of jails and MAT, for practical application, would guide you to. So RSAT-TTA.com, jail-based medication-assisted treatment, and you'll find other things on there also in this space. Including SAMHSA's version of a document, so give a shout out to SAMHSA, obviously, use of medication-assisted treatment for opioid use disorder in criminal justice settings, which was just released, and so it's another very, very good document that you should look at for this topic.
Great, thank you. And I have one question come up about the prescription drug monitoring program. So someone asked, can you speak about the interstate usage of the prescription drug monitoring program? How are states sharing this information, or does it seem more like intrastate usage? Would either of you be able to respond to that?
The PDM, so I'll start, and then I'm looking at Jack so that he can add it.
Yeah.
And we actually work together on a regional program. This is one of the topics that we addressed. So the Regional Judicial Opioid Initiative, or RJOI, looked at this as one of many areas. And so the PDMP is based upon state laws. So states can decide what their rules are within a state in terms of who has access and what information they have access to. States can also decide what their policy is going to be in terms of sharing information. And so again, we worked on a regional initiative to encourage more sharing, recognizing that opioids and many other things do not respect jurisdictional or state boundaries, and so that sharing was critical.
And again, just from working across the country with all sorts of national organizations and jurisdictions, on PDMP, I would refer folks to the pdmpassist.org website. That is the National Training and Technical Assistance Center for PDMP. So while I, like Michelle, we intersect with jails, prisons, courts, mental health, drug treatment, I very much rely on my colleagues who are the kind of deep silo experts in many of the spaces in which we both work, including courts, including opioids, even though we work in that. So on PDMP questions, because they're very technical in nature and they're also very state-specific, it's not a general question like risk-need responsivity doesn't change depending on where you are in the U.S. or in the world for that matter, but PDMP does change across the 50 states. So pdmpassist.org, and again, that is the National Training and Technical Assistance Center out of Brandeis University.
Thank you for that. And someone asked if we could share websites and the apps that were suggested. So we at the Gain Center will follow up with you, Jack and Michelle, to get a list of the different websites and apps that were mentioned and distribute those with the slides today. One more question, and this kind of transitions more into, it looks like the community corrections world. This person said, as an MAT counselor in community corrections, I meet with residents to provide education and enroll them in medication-assisted treatment. Oh, it looks like it's not a question. She was just making a comment about the process they use in the community corrections program she's involved in. They tend to set up care, aftercare, to happen following release and work with each agency to ensure the person is covered with health insurance and so forth.
Yeah, that's excellent. You know, that's really good. And while the 5 critical activities don't talk about that directly, we know that the ability for folks to access MAT and treatment and all sorts of things really does require, obviously, someone to pay for it. And so that's just commenting. Very good that they're out there doing that, as are lots of folks. But that's a super important piece of this.
Absolutely. And we really encourage you all to reach out within your states to learn more about how these various MAT medications can be funded. The insurance companies and state Medicaid programs will vary based on where you're located. And so what is covered will depend on what state you live in. So I really encourage you each to reach out within your state to learn more about how to get people covered under some form of health insurance, as well as to ensure that they're able to pay for the various medications they may need for their medical care. So that brings us to the end of all of our questions. Jack and Michelle, we really appreciate your presentations today, your time, your expertise, and we just really appreciate the wealth of information that you've shared with the field today.
Thank you. Thank you to all the attendees for taking the time out of their day. A lot of good work going on to be part of this. Thank you very much. And we're open to follow up as needed on either the websites, publications, colleagues, partners, whatever we can help any of the folks on the webinar reach to. Great.
Thank you so much. And some of you may have seen a file transfer box pop up on your screen. And so what you are seeing is the way that you can download the various products that we have promised you. First is the certificate of attendance. And so you will see under file name, webinar attendance, just click that file. And then the download button should have turned a darker shade of gray. You can now click the download button, and that will allow you to download the webinar attendance form directly to your computer. Next slide, please. Okay, and we also had a couple of other products here downloading MAT for opioid use disorders in criminal justice settings. So that is, I believe, one of the publications that Jack just referenced. And we also have SAMHSA's Opioid Overdose Prevention Toolkit. Again, this is the original toolkit that Jack has referenced. This isn't tailored to this particular webinar, but still provides a lot of helpful information about opioid overdose prevention and various aspects to include in your programming. And again, if you would like slides for this presentation, please sign up for our listserv. We send out monthly newsletters, and we send out various notifications about our webinars as well as webinar slides. And so this won't come out today, but it should come out shortly. So please make sure you're signed up so that you can get that email when it's ready. And we invite you to join us for our next and last webinar for this fiscal year on Thursday, September 5th at 12:30 Eastern Time. We will be presenting on risk, need, responsivity in reentry and community corrections settings. And we will be sharing about practical applications and programming considerations in order to use the risk, need, responsivity model in your programming. So again, that's September 5th at 12:30 Eastern Time. We welcome your participation. And finally, if you have any further questions, here is the contact information for SAMHSA as well as the Gain Center. And the Gain Center, we are here to provide virtual technical assistance. So if you have a need that you would like to talk through with us or some of our experts, please give us a call and we can set up a time to talk with you about some of the issues you're dealing with within your jurisdiction. So please take advantage of that resource. And thank you so much for joining us today. We will bring this webinar to a close and hope to see you on Thursday.